Floyd here with Curbside to Bedside. Ryan and I are co-casting today. Our topic for discussion today is drowning. There are about 500,000 deaths per year due to drowning, which only comprises about 0.7% of all deaths. So only a small fraction of people die from drowning, which makes it even more important that we spend some time and discuss some pearls and pitfalls in the management of drowning. The number of deaths due to drowning is probably underreported, or the 500,000 deaths a year is probably underestimates the actual number because it doesn't take into consideration drowning deaths due to tsunamis or boating accidents. Before 2002, there were 33 different published definitions for drowning.
I.e. what drowning is.
Yeah, actually, how do you define drowning? Today, the accepted definition for drowning is the process of experiencing respiratory impairment due to submersion or immersion in liquid. Terms like near drowning, wet drowning, dry drowning, saltwater drowning, freshwater drowning, they're no longer applicable and should not be used to define drowning. There is nothing near about drowning. It happened or it didn't.
So a uniform way of reporting data after a drowning event is typically using the Ethstein Template. And I totally butchered that name, so please don't send me any emails. I know I can't speak like a normal human being. And the Utstein Template is as follows. Either there's morbidity, there's no morbidity, or there's mortality. And what that means is morbidity is there was a drowning event and you had some sort of sequela following it, meaning you developed ARDS or aspiration pneumonia or an anoxic brain injury due to prolonged downtime. No morbidity means there was a drowning event, but you were fine. There was no sort of sequela that happened following. And then mortality is pretty simple. You died. You did not survive the event. A submersion or immersion incident without evidence of respiratory impairment is considered a water rescue and not a drowning. So if your head goes down below the water and someone's on top of you and is able to reach in and like pull you into the boat, and then you're like, holy shit, that was scary, but I think I'm okay, and you didn't have any sort of tachypnea or pulmonary edema or any sort of presentation like that, you're simply rescued. You didn't drown.
So understanding the underlying pathophysiology behind drowning is very germane to the treatment of drowning. Generally, what happens when a person is submerged or immersed in the water, they hold their breath until water begins to enter their mouth. Then they voluntarily spit out the water or they swallow it. The next conscious response is breath holding, and that generally lasts about 1 minute. At that time, the patient's CO2 becomes too high, and then the inspiratory drive becomes too strong and some water is aspirated into the airways, which then leads to reflexive swallowing. Patients generally swallow liters of water. At that point, laryngospasm occurs, but it's rapidly terminated by brain hypoxia. And what I found most interesting when researching for this podcast is that little fluid or no fluid enters the lung. If fluid does enter the lung, it's generally less than 30 mLs. So aspiration continues and hypoxemia leads to the person losing consciousness and becoming apneic. From a cardiac standpoint, the initial rhythm is usually tachycardia, then bradycardia or PEA, and then asystole. Now, inside the lungs, what happens is water washes out the surfactant. When you get water hitting the surfactant, it's like putting soap in water. It creates frothy pulmonary edema. The alveoli are also a single cell layer thick. So what happens is you get some alveoli that rupture, you get hypoxic vasoconstriction, and you get atelectasis. So the lung units actually start to close or collapse. And this whole process leads to bronchospasm and inflammation. But the gist of things is that the main problem is there is no oxygen to the brain. This is a hypoxic arrest.
So basically what you're saying, Floyd, is that as opposed to most of the cardiac arrests these run, this is not a primary cardiac cause. This is a primary respiratory cause of arrest. So typically the cardiac arrests we run have hypoxia as a secondary outcome due to cardiac arrhythmia or some other primary cardiac cause, where this is arrest secondary to hypoxia primarily.
Yeah, hypoxia is the cause. Asphyxiation is the cause. And I think that we forget that because of the high performance and compression only CPR blitz that's been going around. We think that all we have to do is provide high quality CPR. That is totally not the case with death due to drowning. So generally, the person who has a sudden cardiac arrest, they have this reservoir of oxygenated blood in their system. So hands-only CPR is fine for the first few minutes in the non-asphyxia type cardiac arrest, because for a few minutes you're able to circulate this oxygenated blood. But in the drowning patient, they've had all of those events that occur during the drowning process essentially cause them to become extremely, extremely hypoxic and extremely hypercarbic. So we said that the initial rhythm is usually tachycardia followed by bradycardia and then asystole. There are times when that person can be in VFib or possibly even VTAC, but that VFib and that VTAC is caused by hypoxia, not myocardial scarring or some type of channelopathy that causes a primary arrhythmogenic cardiac arrest.
That's a pretty solid explanation. So I'm going to talk about rescue. So if you are going to try and conduct an in-water rescue, meaning that the patient is still in the water and you're looking at the water and say, I'm going to go in that water and grab that patient, don't do it unless you are properly trained and equipped to execute such an operation, meaning that you have the training, you have the know-how to use the available equipment if there is any, and if the conditions are okay for a rescue. Water rescue is its own discipline of rescue operations for a damn good reason, and it's because first responders have a tendency to kill themselves doing poorly executed water rescues. So while it may be very difficult to sit there and watch someone, don't make more victims. Don't make the situation worse than it has to be. Which leads into my next point. There's a paradigm as reach, throw, row, don't go for in-water rescue practices for the lay or untrained rescuer. And what that means is if you have a patient that is out or someone who's actually out in a body of water that appears to be drowning or at least in distress, try and reach them with an object, a large stick. Floyd and I work for a fire department, so a pike pole or a New York hook or something that you can reach out that the patient can grab, and then you and your buddies can pull in towards you towards safety. The next one is throw. So throwing, we have throw bags on our ambulance, which is just water rope that you can literally throw to a patient and have them hold on to and then just pull them in. So you can throw a rope or throw a life preserver or whatever you have at your disposal to remotely essentially capture them and then bring them into you again. And then row is taking a boat or something like that that is at least somewhat stable and everyone knows how to operate, and going out into the body of water and trying to manually pull that patient out. As always, don't get anywhere near water if you're going to execute a rescue operation without a life preserver. Firefighters, don't wear your fucking turnout gear near water. Please, for the love of God. That's so dumb. I know you can technically float in it, and yeah, just don't. It's stupid. Just wear a fucking PFD.
But you can't move in it.
Yeah, you can't move worth shit. So Ryan's rant: wear your PFD when you're doing anything with a patient near water. Just do it. It's not that hard to put on a life jacket. And if you don't carry them on your trucks, raise the point. Are you likely to ever have to use it? Probably not. But when you need it, you need it. We don't want to create any second victims. So if you're in the water and you're properly trained to be in the water and the patient has a pulse, mouth-to-mouth or mask-to-mouth resuscitation is permissible and a 3 times greater likelihood of surviving as compared to someone who was taken to land and then having ventilatory support is realized. So basically, if you're properly trained to get in the water and actually rescue that patient, start ventilatory support as soon as you can if they have a pulse. They're more likely to survive than if you just drag them to land and then start everything there. So CPR in the water is probably not going to work unless you have a specialty device with floats that you can put under the patient. And even then, it's still likely to not be that great. There's still little reason to immobilize a patient in the water or maintain C-spine precautions unless you have a very high index of suspicion for some sort of diving injury. And even then, the incidence of C-spine injuries in drowning events is between 0.5 to 5%. And that's just based on the different literature reviews and stuff like that have been conducted up to this point. And without any obvious signs of trauma or a known fall or diving event like I mentioned earlier, routine cervical spine immobilization is probably unnecessary and can delay providing oxygen to the brain. Remember, we need to get ventilatory support on these patients as soon as possible. Dicking around with a C-collar is not helping that end at all. And if the patient's awake, then if you really suspect it, you can follow your standard spinal clearance algorithms.
The only thing I would add to that, Ron, is that yes, mouth-to-mouth resuscitation or mouth-to-mouth in-water resuscitation does result in a three-time greater likelihood of surviving, but that doesn't apply to the patient who's in the water and has a cardiac arrest. In that case, you want to rapidly extricate them from the water as soon as possible. But I think in-water resuscitation, even though mouth-to-mouth resuscitation would result in a greater likelihood of survival, me as your typical first responder, I'm not trained on that, and it seems technically difficult. And honestly, I would not know how to do that.
Which goes back to the previous points I made, which is know your lane. Don't execute a rescue and get yourself hurt. And if you're in unfamiliar territory, do what's best for you and the patient. So don't put yourself in a position to become a victim yourself. So for land resuscitation, we're going to kind of switch up the conventional norms of resuscitation, at least in the cardiac arrest patient. So typically we're taught CAB, circulation airway breathing. So we prioritize excellent compressions and doing high performance or crew-based CPR. And then we get on to ventilations, and airway management is typically deferred until later on in the arrest. But in these patients, as Floyd mentioned earlier, this is a primary hypoxic arrest. So it's ABC, ABC, ABC. We need to control the airway in these people. We need to get ventilatory support on them quickly. And then we can start looking at cardiac causes and initiating CPR and stuff like that. But we'll start with the basics. You can do mouth-to-mouth, you can do mask-to-mouth, BVM, so on and so forth. And you don't necessarily have to intubate them, but just make sure their airway is patent. You can use BLS adjuncts, BLS positioning, whatever floats your boat there. But you can delay placing an advanced airway for quite some time, because the thing we want to do is positively ventilate these patients with high levels of PEEP and get oxygen in them. So there's really no place for, quote, hands-only CPR in these patients. As professional rescuers, as clinicians, really there's no place for hands-only CPR for us either, because that's a lay public sort of thing. We have high-performance or compression-focused CPR, but it's not necessarily hands-only.
And I describe it as these patients having a severe oxygen debt.
Basically, that oxygen debt isn't going to be repaid without positive pressure ventilation and supplemental O's. Yeah, and you actually, so Ron mentioned that it's ABC. Even the AHA still recommends ventilation first. And you probably won't hear that in your typical ACLS class unless you read the actual guidelines. They are buried somewhere deep within. And I think that they recommend you do 4 or 5 rescue breaths before you perform CPR. Other sources say to give 2 rescue breaths, but the amount of rescue breaths isn't what really matters. What you should focus on is just getting oxygen to that patient via positive pressure ventilation. I want to go back real quick, Ron, to the rescue section. Okay.
I found it interesting when we were researching for this podcast that if you get the person in a boat, that it is okay to utilize an AED.
Oh yeah, good point. I forgot about this part.
Yep, in the boat, even when it's moving, because with modern rhythm algorithms, the artifact caused by a moving vessel does not significantly impair its ability to analyze or accurately determine a rhythm. Modern evidence suggests that if you use an AED in a wet environment, that there's not an increased risk to you or the patient, as long as the pads are placed firmly on the chest and that you're not in direct contact with the patient.
Yeah, and just to clarify a little bit, when I say ABC, like Floyd mentioned, I don't mean to just go reaching for the laryngoscope blade. You can just do a head tilt chin lift or a jaw thrust and then get that BVM or that mask on them as soon as you can. Yeah, you just want to make sure you've got a passage for air to go. Now, you're going to get, with a decent drowning case, you can probably expect an above normal level of resistance as you're probably used to dealing with a normal arrest. That's probably going to be a byproduct of some sort of aspiration. And we're going to get into why that is based on the pathophysiology that we outlined earlier and using high PEEP strategies to kind of help these patients out a little bit.
I think I would actually debate laryngoscopy or even place in a supraglottic for at least, the first 10 minutes, because you don't want to do anything that would get in the way of delivering oxygen, high flow oxygen to that patient.
Agreed.
And we mentioned earlier that these patients can be in VFib and possibly even VTAC due to severe hypoxia. But even then, even if they are in a shockable rhythm, the airway still takes priority in the drowning patient because your defibrillation is not likely to be successful until you restore oxygenation to that heart.
So one thing to be aware of is acute pulmonary edema. And I mean, it just kind of makes sense that if someone is immersed or submerged and they have a drowning event, there's probably going to be some degree of aspiration or pulmonary edema present. So Floyd mentioned earlier that the presence of surfactant in the lungs. Well, when you take exogenous water and you add it to surfactant in your lungs, which is basically soap, what you get is a foam and a continuous edematous, exudate out of the patient's mouth that looks like your EMT school stereotypical decompensated CHF, right? That frothy edema. That's what you might wind up seeing. And one little point of minutia is there's no need to just empirically suction these people unless you have vomit or lots of frank water. You don't need to just see edema and be like, oh, I've got to grab the suction unit and get all of it out. We can solve that pulmonary edema with PEEP. Now, if you have lots of water or just use your brain. If there's lots of stuff coming out, lots of vomit, lots of water, then naturally suction it. But that very aerated sort of edema, you don't really need, per se, to suction immediately. You want to get ventilatory support on them first. Often that foam will be continuous and can be difficult to control. What we want to do is just bag it down. So use high PEEPs. Maybe start at 10 versus your normal 5, like you should probably have on your BPM to begin with. And then you can titrate it up. I'm not sure if there's a max range on PEEP for these patients, but I'd assume it's pretty high. Even if they are in arrest, because that's going to be the primary cause of arrest. Typically we don't want to use high PEEP in cardiac arrest because it increases the amount of interthoracic pressure and decreases coronary perfusion. But like Floyd said earlier, even if that patient's in a shockable rhythm, it's going to be very difficult to convert that patient successfully without reversing that oxygen debt. And one of the ways we reverse that oxygen debt is using positive pressure. That'll help deliver that oxygen to the alveoli. Conventionally, there's been some use of the Heimlich maneuver by lay and professional rescuers to try and, squeeze out that extra water. Just don't. It's not going to make any bit of difference. There's actually surprisingly little water that's generally aspirated into the lungs in even severe drowning cases. Now, granted, if you've been in the water for 2 hours, every orifice is going to be full of water. But for the type of patient we're talking about, which is the at least halfway fresh drowning, you're probably not going to have a whole lot of water in the lungs proper.
Yeah, I think autopsy studies show that there's usually less than 30 mLs of water that's actually aspirated into the lungs.
Stomach, different story, especially due to that reflexive swallowing action. But the Heimlich maneuver or some other associated manual maneuver like that is only going to delay the administration of oxygen. So if I were to liken this to another medical condition, ventilating and oxygenating these patients rapidly is akin to giving epinephrine and anaphylaxis. You want to do it quickly, and nothing else trumps that priority except for your personal safety.
So let's say your patient is awake. Then if they're awake and they have a lot of rails and they got a little bit of foam in their airway, then you can consider placing them on CPAP. If they're not awake, but they have an advanced airway established and they're on a ventilator, then you want to use an ARDS approach. Now, this is a recommendation from the WMS practice guidelines for drowning. They do recommend using an ARDS approach. It's basically a low tidal volume, which is 6 to 8 cc's per kilogram, and then titrating your FiO2 and PEEP up in tandem until you can maintain an adequate oxygen saturation. So you're going to use a low tidal volume, about a normal respiratory rate, 16 to 18 breaths per minute. You want enough to maintain euapnea, and then you're going to take your PEEP and FiO2 up in tandem to maintain an adequate FiO2. So who should be resuscitated? Who should we attempt resuscitation on? Of course, you have to take into consideration your own particular environment. You have to consider your resources and how much risk there is to you and your team. You got to consider your own safety in this. But let's say you have the capabilities to rescue someone. The most important predictor is the duration of the submersion. The evidence that we have shows that if they're submerged greater than 30 minutes, then the prognosis is very poor. There are, however, some case reports of survival to neurologic discharge even with a prolonged submersion, but this is usually in young children and in a water less than 43 degrees Fahrenheit. But most of those cases utilize some things like ECMO. So the WMS guideline recommendations say that there's minimal chance of neurologically intact survival if the submersion time is greater than 30 minutes in water greater than 43 degrees Fahrenheit. But if the water is less than 43 degrees Fahrenheit, they say that there's a minimal chance of neurologically intact survival with a submersion time greater than 90 minutes. There is a Dutch study that they mentioned, which was a review of 160 children younger than the age of 16 that were hypothermic. 98 of those received CPR for more than 30 minutes, and only 11 of those survived to be discharged, but they were all neurologically devastated.
And one other point to bring up is that based on the evidence that's available right now, submersion times greater than 10 minutes are obviously correlated with an increase in mortality or survival with severe neurological issues. More than 25 minutes of resuscitation, or if you're in a situation where there's a pretty long time between you and advanced medical care, that correlates pretty well with negative outcomes.
So when do you stop resuscitative efforts? Like, when do you say we've done CPR long enough? Traditionally, in standard cardiac arrest, we would say, well, we work them on scene for 20 minutes, and if they're still in asystole, then we'd call for orders. The WMS guidelines recommend that you should consider ceasing resuscitative efforts after 25 minutes of continuous CPR, but I don't like any rigid guidelines. I think that you have to consider it on a case-by-case basis. Is the patient hypothermic? Did they have good CPR before you got there? Were they actually providing ventilations to this person when you got there? That could be a determining factor, because if they've been submerged for 30 minutes and then they pull them out of the water and no one tried to breathe for them, then that would probably weigh heavier on the side of calling them after 25 minutes versus working them longer on scene. Hey guys, Floyd here. I had to go back in post hoc and add this because I felt like we needed to elaborate a little bit on resuscitating the patient who drowned in cold water. The WMS recommends that you should consider ceasing resuscitative efforts after 25 minutes of continuous CPR. And I want to explain why that is. You're familiar with the mantra, they're not dead until they're warm and dead. There was a Dutch perspective study conducted of children who drowned in cold water. And that study showed that no child in asystole who was resuscitated for more than 30 minutes survived without being neurologically devastated. And I'm quoting that directly from the WMS guidelines. Now, there was another large study conducted by Kwan et al. Involving adults who drowned in cold or very cold waters, showing that out of 1,094 victims, the majority had bad outcomes. Of those with good outcomes, they were likely to be submerged for less than around 11 minutes. Brown et al. Found that there is a neuroprotective effect in avalanche victims, but that did not apply to those who asphyxiated first and then became hypothermic. And in your drowning patient, they're more likely to asphyxiate first, becoming very hypoxic, and then after being in the water for a little while, then becoming hypothermic to the point where it is neuroprotective. But the neuroprotective benefits of cold water is probably lost to that patient because they were likely very hypoxic first before becoming hypothermic. I think that mantra, they're not dead until they're warm and dead, is probably a little overhyped. More and more data suggests that there's not as much of a neuroprotective effect of cold water drowning as once thought. And that mantra is probably only applicable to the patient who becomes hypothermic before going into cardiac arrest or becoming hypoxic. Now, let's say you rescued somebody from the water who had some form of respiratory impairment, but you were able to resuscitate them, and now they are awake. What should their disposition be? Let's say you're in a rural setting, or you're doing something very strategic, and you don't want to evacuate that person unless you absolutely have to, or evacuating that person could pose an increased risk or danger to you and your team. Well, there was a chart that the WMS guidelines adapted from Cushing et al. That grades the mortality based on the pulmonary and cardiac exam. And basically, if the person is awake, they have normal or clear breath sounds, plus or minus a cough, then their mortality rate is 0%. But if they have rales and a little bit of foam in the airway, then it becomes 0.6%. And then you progress on to acute pulmonary edema with a radial pulse, then it's 5.2%. And once you get to pulmonary edema with hypotension, it's 19%. And then when they have a respiratory arrest, their mortality is 44%. And if they're in cardiopulmonary arrest, then their mortality is as high as 93%. So you can see that it's based mostly in the awake patient on the pulmonary exam. The worse their symptoms are, the higher their mortality is. And in summary, drowning is a brain problem, not a heart problem. Your number one goal is to get oxygen to the lungs and therefore get oxygen to the brain. And that's all. Ryan, you have anything to add?
Air goes in and out, blood goes round and round. Any variation in these processes are bad. Until next time, my mind will fail me, and I would forget what I would say. It's like every time, not just next time, though.
What's our Twitter handle?
EM_resus.
No.
So on social media, you can find us on Twitter. I always feel so weird saying at. Like Star Wars. So our Twitter handle's at curb to bed? Yeah. It's
Curb to bed.
Yeah, I always forget our Twitter handle. Floyd runs our social media blitz. That's too much for me.
Very poorly, I might add.
And you can find us on Facebook at Curbside to Bedside, or email us at curbtobed@gmail.com.
All right. Thanks, guys.